Hello, friends. Welcome to another session of Radio Shorts. And today we'll be talking about a subset of topic which is considered very difficult for residents, that is interstitial lung disease. We'll be looking at two different and very interesting cases. We'll be trying to understand what is UIP, and we'll also be trying to understand what is not UIP. So let's have a look at our first case. Our first case is that of a 65-year-old male who's a chronic smoker who's now complaining of shortness of breath, and the pulmonologist is suspecting an ILD. But what is strange in the clinical history is this fever, and the patient is also having leukocytosis. So whenever there is an elderly male who's a chronic smoker comes to you with leukocytosis, you always think about some form of infective pathology like pyogenic pneumonia. Now, there's a word of caution before I start showing you the case. I want you to know that in HRCT and in interstitial lung diseases, history is paramount. Paramount. Why? Because there is a very limited spectrum in which the lung would respond to insults or diseases. But the clinical history will help us in identifying and diagnosing the case as a particular interstitial pathology. So let's have a look at the CT images of the patient. So these are the cine images of the CT scan of the same patient. I want you to have a look at the CT images starting from top to bottom. So what did you see? What are the observations that you could make? Let me just reiterate the findings starting from the apex. So when I look at the apex, I can see something wrong. What is this something wrong? I can see some thickening here, some thickening here, some thickening here. So I can see a reticular pattern. Normally, in a normal lung parenchyma, you won't be able to identify these interlobular septa. But here, I can see these interlobular septa being very thick. I can see some linear hyperdensities. Now, these linear hyperdensities in HRCT are called by the name of reticulations. So I do have a reticular pattern. Now, these things are pretty much symmetric. I can see them on the left side and I can also see them on the right side. I hope all of you can appreciate this thickening of the interlobular septa. Then, when I'm going from top to the mid lung zone, again, I can see the same findings in a much better and a florid fashion. I can see that there is thickening of the intralobular septa as well, and these changes are also symmetrical. How do we differentiate between interlobular and intralobular septal thickening? Interlobular septal thickening actually involves the secondary pulmonary lobule, and it is in this form, that is hexagonal. But when you see this peripheral linear reticulations, which are giving you a fishnet type of an appearance, that is a intralobular septal thickening. So we can see some intralobular septal thickening here as well. We can see some intralobular septal thickening here, everywhere. Now, if you have seen this case till now properly, then one thing that you might be able to deduce is these reticulations are peripheral, predominantly peripheral. The other word that we use is subpleural. So we have made an important observation. We have seen an increased number of linear opacities, which are nothing but reticulations, and they're all peripherally located. Let's go further down. When I'm going further down, what do I see? Now here again, I can see that there is septal thickening, clear cut, here, everywhere, which is both interlobular as well as intralobular. But also I can see that there is some pulmonary parenchymal distortion. Look at this lung parenchyma. It appears as if there has been some form of a volume loss resulting in cicatricial changes in the lung parenchyma. Here, I'm seeing something different. I can see an area of airspace of opacification, which is not usually seen in interstitial lung diseases. What is this? Let's go ahead and try to decipher it once again. I can now even see some cavitation in this. Now, cavitation usually doesn't occur in ILD, so it means that there is something gone wrong with this case. Let's go further down. Here is where the main pathology is lying. In the lung basis, look at the interstitial pattern. Look at the interlobular and the intralobular septa. They're all thickened. And we can also see some areas of honeycombing. Now, why is this honeycombing and why is it not emphysema? Emphysema would be seen as one layer, just like this. But if you see multiple stacks of cystic areas, one over the other, that's honeycombing. So we can see some subtle areas of honeycombing which are there at the lung basis. So this is all about our case number one. And I hope everybody of you would now be able to enumerate the findings. We can see that there is a reticular pattern in form of intralobular as well as intralobular septal thickening. And we can also see that there are early areas of honeycombing. One other very subtle point that you might have appreciated is you can clearly see that when I'm going from top to bottom, the lung apices are least involved and lung bases are most involved. So we do have another thing which is increasing apico-basal gradient. Some people also call this as subpleural basal predominance. So these are the basic findings that we could see in this case. One additional finding, which is not related to an ILD pattern, is this area of cavitation. And this area of cavitation is located in the left lower lobe. So what do you think it is? We've been taught since ages that whenever you see honeycombing, always think about UIP. So probably you're all also thinking about UIP. But hold your decision for a second. We'll have a look at our case number two, and then we'll try to understand what is UIP and what is not UIP. Now, our second case is that of a 45-year-old male who's a non-smoker and who's coming to us with shortness of breath. Now, if you would have observed carefully, there are two basic contrasting differences between our case number one and case number two, depending upon the clinical history. First is the age of the patient. Now, this is a relatively younger patient. The other patient that we saw was 65 years of age. This patient is a non-smoker, so we don't expect emphysema in him. And still, he's complaining of shortness of breath. And on an X-ray, there was some interstitial lung marking. So pulmonologist also thought of some form of an ILD. What is this ILD? Let's have a look at this second case. Now, this is the CT cine scan of the patient starting from top to bottom. Have a good look at it. Take your time. What are the findings that you could make in this particular case? Let me again start it from the beginning. So here what I'm seeing is, what is this? Does this look like emphysema to you? It doesn't, because I can see multiple layers. This is one, this is two, this is one, this is two. Again, this is one, this is two. Secondly, when the patient is a non-smoker, you don't think about emphysema. So we do have honeycombing, honeycombing. And whenever we see honeycombing, what is the first thing we think about? UIP. Let's go down. And what do I see now? I can see that there is again a florid honeycombing. And this honeycombing, if I ask you where is it located? Yes, it is located along the peripheral aspect, in that is in the subpleural area. But look at this area. Look at this place. Now we are seeing honeycombing at a place that we don't expect it to be. We are even seeing central areas of honeycombing. But this is not over yet. Let me go down further. So when I'm going down further, what do I see? What has happened to the bronchi? You don't see non-tapering bronchi here. I mean, the bronchi are dilated. And this is not only seen on one side, on the other side also you can see that the bronchi appear to be dilated and air-filled. So what is this thing called as? When you see dilated bronchi in presence of an interstitial lung disease, we call this thing as traction bronchiectasis. Traction bronchiectasis. So we do have a dilatation of bronchi, which is because of the adjoining pulmonary fibrosis. And finally, when I'm looking at the lung basis, I do see traction bronchiectasis, but do you see any honeycombing here? No, I don't see any honeycombing here. So honeycombing was present in the apex. There is a contrasting difference between the two CTs that we saw. In the previous CT, the honeycombing was located at the basis, but here the changes are most marked at the pulmonary apex. Here what I'm seeing is an increase in the lung attenuation. If you see carefully, this lung appears more white, more hyperdense as compared to what is expected to be of a normal lung. So I do have some areas which look like ground glass opacification. Plus, I do have honeycombing, which is not showing an increasing apicobasal gradient, which is not showing a subpleural basal predominance. Now, to have a better understanding of the two pathologies, let's have a look at the static images of the two cases one by one. So this is our case number one. What do you see in our case number one? We can see that there are peripheral subpleural areas of honeycombing which are located predominantly at the lung bases, and the lung apices are pretty normal. Here we can also see that this area is the one which is consolidated, associated with cavitation. Let's have a look at our case number two. In case number two, we can see all this honeycombing is predominantly seen in the upper lung zones. Lower lobes are also affected, but the lower lobes are affected much lesser as compared to the upper lobes. Now, my question to you is, I'll give you a hint. One of them is a UIP and the other is not. So where are you going to put your money on? Is this a UIP or is this a UIP? I hope majority of you got it correct. This is a UIP while this is not a UIP. It is a fibrosing ILD because I can see all signs of fibrosis, but it is not UIP. Why it's not UIP? Because the findings which are important for UIP are basal and subpleural distribution, reticular opacities, traction bronchiectasis, and honeycombing. And the most important point is absence of inconsistent findings. And one of the most important inconsistent finding is a disease which is predominantly having an apical or a mid-lung zone predominance. So because the first case had a basal predominance, we can call it UIP. The second case had an apical predominance, we cannot call it a UIP. So these are the predictive UIP patterns, and the difference between predictive and possible UIP is only one. When you don't have honeycombing, but you have rest of the three features, then you can call it a possible UIP pattern. So now, when we have a look at both the images, one on one, case number one and case number two, I hope you will remember forever in your life that whenever you see honeycombing in the upper lobes, it cannot be UIP. When you see honeycombing in the lower lobes, it is always likely to be UIP. And in this case, we can also explain the fever because the fever was caused due to the super added infection resulting in consolidation and cavitation. So final answer to be given is, if this is not UIP, what it is? Many a times we cannot tell what it exactly is, but there was a clue which was hidden in this case, and the clue was the soft tissue window. We could see all these plumpy lymph nodes scattered throughout the mediastinum, and this is the reason why we gave a presumptive diagnosis of sarcoidosis, which was confirmed on endobronchial ultrasound. So this is all about UIP. This is all about when to call an ILD as UIP and when not to call an ILD as UIP. Also, it highlights that every honeycombing is not UIP. If the honeycombing is having an apical predominance, don't think about UIP. If it is having a subpleural basal predominance, it's very likely to be UIP.